El Colegio Mexicano de Ortopedia, en su 75 aniversario, presenta su segundo Congreso Virtual 2021. El doctor Thorsten Gehrke estudió medicina en la Universidad de Hamburgo. Fue asistente de investigación en anatomía y en ortopedia en el Instituto de Anatomía y en el Departamento de Ortopedia de la Universidad Christian Albrecht de Kiel, de cirugía en el Johannite Hospital de Gstaad y de cirugía en la Clínica Endo en Hamburgo, Alemania. Fue ortopedista senior en el Departamento de Ortopedia, Universidad Christian Albrecht de Kiel y ortopedista senior líder en la Clínica Endo en Hamburgo, así como jefe de ortopedia en el Regio Clinics en Wedel, Alemania. Desde 2005 es director médico y ortopedista y cirujano en jefe de la Clínica Endo de Hamburgo. Ha sido profesor a tiempo parcial en el campo de la medicina deportiva en la Sociedad de Gimnasia y Tiempo Libre en Hamburgo y en la especialidad de ortopedia deportiva y anatomía deportiva en el Instituto de Ciencias del Deporte de la Universidad Christian Albrecht de Kiel, Alemania. Desde 2010 es profesor a tiempo parcial en la especialidad de medicina deportiva en la Escuela de Medicina de Hamburgo, Alemania. El doctor Gehrke hablará sobre por qué sigo utilizando vástagos cementados en mis pacientes.
Hello everybody, especially of course in Mexico, which is one of my favorite countries all over the world. All of you know it. I love to travel to Mexico and I love to enjoy Mexican lifestyle. It's such a pity that we still not able to organize these kind of meetings in person, just virtual, but at least I'm virtually in Mexico now. My talk is about cemented stems, and I'd like to answer the question, why do I still use cemented stems in my patients? Here are my disclosures. In the endo clinic, we are doing about 8,000 joint replacements a year. And from this, it's almost 3,000 total hip replacements. And of these 3,000 total hip replacements, we still perform 1,000 cases in the cemented manner. So the question is, why do I still cement my stems, especially in older patients? The answer is very, very simple. It's clear, because of the better results of cemented stems in older patients. There are a lot of papers about it, a lot of reports about it. Probably this is one of the most interesting and most important paper. In this paper, they are talking about the uncemented paradox. Uncemented paradox means that despite the fact that all over the world, in all registries worldwide, cemented stems are working better in patients older than 75 years, most of the surgeons worldwide are performing uncemented stems even in this age group. Here are some examples. This is Norway. In the registry of Norway, cemented stems are working better in patients over 75 years. If you see the RR, the value, you see uncemented stems are significantly not as good as cemented stems. In Australia, the same situation. Cemented stems in patients older than 75 years with much better results, much lower complications. This is a NARA registry, which is working with about 700,000 or 800,000 patients in the meantime, where you can clearly see that the cemented stems in almost all age groups, but especially in the older age, working better due to the lower complication rate. Especially two kinds of complications are much more combined with uncemented stems, and that's dislocation and periprosthetic fracture. And this explains the difference in the outcome, because the fracture rate and the dislocation rate in uncemented stems is significantly higher. Some other papers here, it's a paper from Australia. Australia is mostly and mainly uncemented country. And they compared the 3 best cemented femoral stems with the 3 best cementless femoral stems in the Australian registry. And at the end, you see that the cumulative revision rate is much better in cemented femoral stems after 13, 14 years. So the cemented stems, even in Australia, in age older than 75 years, are working better. Some other papers, this paper is from Canada, for example, and from Australia as well. Here they report an early revision rate, which is more than 9 times higher in cementless stems than in cemented stems. And they concluded in this paper that cementless femoral stem fixation in patients 75 years or older is associated with a higher early revision rate. So to summarize, uncemented stems are leading much more common to periprosthetic fractures, what you can see also in the German registries, where also cemented stems in patients older than 75 years are much better. But what is the prerequisite for these results? It is mentioned already almost 50 years ago by Sir John Charnley that the perfect cementing technique is the condition sine qua non. What is a perfect cementing technique? The modern cementing techniques include 3 very important parts: proximal seal, usage of pulsatile jet lavage, and a distal cement plug. The key factor is always, for a good cementing technique, we are always aiming for a very good cement penetration into the cancellous bone. For this, you need 3 goals: dry, bloodless surface, which you can reach by using jet lavage systems, bloodless, fatless, cancellous bone. You have to irrigate it out of the bone cement to get a very good cancellous bone exposition, where the bone cement can penetrate deeply into it. Sir John Charnley was a guy who was saying cement is not a glue. Cement, the long-term results of cemented stems are depending on the depth of the cement penetration into the cancellous bone. Hypotension, anesthesia, it's always a little bit difficult to reach it, to discuss it, and to convince the anesthesiologist to lower the blood pressure. And what we need is high local pressure during introduction of the cement into the bone. For this, to reach this goal, we need a distal cement plug, and we need a proximal seal to press the bone in this bone cement into the cancellous bone. So pressurization is the main goal of the modern cementing technique. Here, a short video, you see a patient of mine who was about 80 years old or 82 years, You see weak bone, osteoporotic bone, a lot of fat and blood in the femoral canal, very thin cortical bone. This is, in my opinion, an ideal indication for a cemented stem. I'm not brave enough to perform, in those cases, a cementless stem. And here you see, by using the pulsatile jet lavage, you clean the bone in a perfect manner. And into this cancellous bone, you can press the cement very well. This is a distal plug, another irrigation, introduction of the bone cement, here drying the canal, and then you can fill up the canal with bone cement, and then you can pressurize the bone cement by using your thumb first and by using this proximal seal to help the cement interdigitize into the cancellous bone, and then you can cement the stem in. So our philosophy is always, in patients younger than 75 years, we are doing cementless stems. In patients older than 75 years, we are going for hybrid cemented stems in combination with cementless plugs. But during the last years, we changed our philosophy because due to the literature, to the most recent literature during the last 2 to 3 years, where it was reported that women are on a significant higher risk to get some kind of complication with cementless stems. Here, for example, the Nordic arthroplastic risk, where they came to the conclusion that women over 70 years old have a 17-fold increased risk for periprosthetic fracture by using an uncemented stem. And even in US, the Mayo Clinic reported within the first 30 days a 10-fold increased risk in uncemented stems when compared to cemented stems, especially in women and patients over 65 years. That led to the fact that we changed our philosophy into the following: younger than 75 years, if it is a male, we go for cementless stems. In females, we perform cemented stems, the hybrid, if the patient is older than 70 years. So our cutoff for males is 75 years in the meantime, and for females is 70 years for cemented stems. So my take-home message is modern cementing technique is mandatory, of course. Most important steps are the lavage and the pressurization of the bone cement into the cancellous bone. In patients older than 75 years, cement is the better option. And we can differentiate in women older than 70 years and men older than 75 years. And cement has a significant lower fracture and dislocation rate. I'd like to thank you very much, but I want to show you which kind of cemented stem we are using, because there are many cemented stems on the market. For us, due to the better results and best results in the literature, is the Link Lubinus SP2 stem, which was developed in the late 80s. And due to the registry results, for example, in Sweden is still the most common stem, and the SP2 stem is still the #1 regarding survival rate. So that's why we are using this stem always in our patients. I'd like to thank you very much and wish you a great event here in Mexico. Thank you.